All right, welcome back. We're having a great conversation with Blake Anders, Doctor of Physical Therapy at PhysioPoint in Cedar Lake, Indiana. And today, Blake, what I wanted to do is talk a little bit about specifics. Maybe our audience could benefit from the expertise and the experience that you've had in treating specific types of issues. I, like you, don't like to treat ICD-10 codes, and I certainly don't like to chase pain, so we do like to look at impairments. And there are definitely some patterns, but there's some unique opportunities with the way that you approach things. And so one of the things I want to do is just go way deep, and let's just talk about low back pain. We see that a lot with your athletes. We see that a lot with our general population. Walk me through, let's just go with maybe in a specific example. What are you doing when somebody comes in and they go, oh, I did some weekend warrior stuff last weekend. It's Monday morning and they've got pain showering down below their knee, into their foot, numbness and tingling, and they're at their wit's end. Have you seen that person before, and how do you approach them?
Yeah, I've seen that person, and generally the first thing that comes out of their mouth is the word that starts with S.
Yeah.
And that is sciatica. The thing that I don't like is putting labels on stuff. I'm really not a big fan of that, and because of it, I try to stay away from that word because it puts a category on something, and everybody loves Dr. Google.
Yeah.
And what tends to happen is when they find Dr. Google, they tend to know way more about the stuff coming into the door than you, at least in their mind.
Yeah.
And that's not a slight. That's a good thing. Having access to information is important. But organizing that information is our job as the clinician. And so for me, getting the history is really important. The mechanism specifically, if they've got a directional preference, that's something I'm trying to find out. Specifically, if they're having numbness or tingling, I want to rule out any red flags. So, I'm making sure that they haven't any issues with bowel or bladder. I'm making sure that in my testing, I'm looking for things like clonus, upper motor neuron lesion issues. Just kind of taking that off of the plate so that when I do get to the education piece, they're understanding that, hey, this is not a red flag. We just need to calm the system down and go from there. So that's kind of my first step in general.
Yeah. I thought you were going to mention a different S word. No, not the S word. No, surgery, actually. And
yeah.
What's interesting to me, I'll segue back to the back, but whenever I say the word rotator cuff to a client that's over the age of 50, I'm waiting for them to coil back, because the only two words they hear together are rotator cuff and surgery, and it's like, no, there's tendonitis, there's a lot of things that can go on. It's like saying, tooth. That doesn't mean you're gonna get a tooth pulled. It's a piece of anatomy. But I can relate to you sometimes when people are like, oh, they have Dr. Googled it, they tell you what's going on. And I actually don't mind too much when people try to educate themselves, but it does sometimes require then some gentle coaching. One of the things that I've seen before is somebody with that exact scenario that I posed, literally going for surgery pretty right away. Now, I'm not going to try to say that, they were wrong, because the pain will make you do funny things. And, but I also typically ask them, and I only find out about this months or years down the road, when I ask them to replay that story, and I say, did you get therapy? Did you take an Advil? Did you get an epidural? There's all sorts of things between and usually that scenario, for those of you that don't know, oftentimes that scenario is disc related, and the disc may have herniated or maybe tore a little bit, and it causes inflammation on the nerve root. And nerve root, at least the first few millimeters of it, is part of the spinal cord and brain, so that then would be considered an upper motor neuron. Now, once it starts exiting the hole in your spine, that is called the foramen, then it becomes a lower motor neuron. But while there's a bomb that just went off and there's fire on that nerve, it hurts. But no thought is ever given to what do we do to calm that fire down, to see what's going on. Let's just cut it out. And I've had my tonsils out, and if your appendix is blown up, you cut it out. I'm not saying there's not reasons to have things cut out, but as the first thing to do, I was like, oh, I don't know what you see, but what I see oftentimes is once they've cut that disc out, now there's negative space. Okay. And now there's instability, meaning the spine moves too much, because where it used to be a nice fat disc, now it, a little bit, squirted out or whatever you want to call it. And there's various degrees of that, and they just cut it out. And all of a sudden we have a lifelong history of problems where I've seen the opposite, where an epidural, even MRI evidence shows that it's absorbed afterwards, after an epidural or after time. So tell me about what your approach would be when somebody is in that state, not the acute phase where they're at their wit's end, but they come in and they go, I had surgery 10 years ago. I was fine for a while, but now my back keeps going out.
Yeah.
What do you do with that one, or what are you thinking? I know these are general questions, but what's your approach when you hear that?
Yeah, typically when somebody's having pain, I talk about good signals and bad signals.
Okay.
As a physical therapist, movement is really kind of our strongest pillar. And, a lot of times what you touched on with regard to surgery, even if you talk to a surgeon, they're also going to tell you, let's be as conservative as possible.
Totally.
For the most part.
Yeah.
And so we have the opportunity to work with a lot of really good surgeons in the area, and they will refer to us as physical therapists. But if I am having somebody who's having that recurring issue, let's get back to the good signals and bad signals. So essentially what I'm educating them on is when we get when we're getting pain, when we're experiencing pain, that is something in the body, some type of tissue, whether it's the joint or it's the capsule or it's muscular anatomy. A pain signal is a request for change. It's a bad signal to the brain. When the brain gets a signal that is bad, it says, how do we compensate to make it not painful? And because of that, if we've had surgery and say it changes how we walk, thousands and thousands of reps of walking is going to change an entire motor pattern. That change in motor pattern may cause some other issues elsewhere, up or downstream. So if they've had some surgery on their back, a lot of times, months down the road or years down the road, they have issues with their hips. And that's because of a change in the motor pattern where our software, our brain and our spinal cord has revamped or rewired a motor pattern throughout the system to make them go, well, this is how you walk without pain, and that's how they associate normal walking. And when we can change that motor pattern back to more of a normalized gait, and their hip pain goes away, that helps them understand, oh, this is the difference between a good signal and a bad signal. And so if somebody with back pain comes to me, I'm trying to find movement patterns and movements of the back that are good signals.
Okay.
So we've got a map.
Do more of those.
Yeah, do more of movement is not going to, this is a great example. I had a client in last week. They've had fusion in the lumbar spine. And what they came to me and said was, I'm scared to move. I can't do these things. And what was ironic about the situation was this individual told me that they couldn't do, here's a great, they laid down on the table. They said, I can't move. I can't extend backwards. I used to be a person who I would lay on my stomach. I would push up and would get a lot of relief from that.
Okay.
They did that in front of me.
Yeah.
And said that they couldn't do that. And so for me, I immediately asked, was that painful for you?
Yeah.
And obviously when you need to be respectful of the fusion itself. However, when she did it, she wasn't experiencing pain. And then she continued to go on in multiple different movement patterns where, to me, if she walked in the door and I had no idea she had a lumbar fusion, I would go and say, what's the issue?
As her perception is she couldn't do it.
100%. And she did all of those things in front of me pain-free. So for me, that is much less about the orthopedic issue going on and much more about the psychological, biopsychosocial.
Biopsychosocial?
Exactly.
Yeah. Yeah, so she was self-limiting.
Exactly.
To add to that, I think that I don't disagree with you that some of it could be related to fear avoidance.
Yep.
But when she says, I can't do it, that's a cognitive statement. And I think a lot of times, I don't know if it's more or less than cognitive. I think some of it is automatic, or maybe we could say reflexive.
Yeah.
And so what we do a lot of times is we say, say the back bend example. Let's say they do it and they use full range of motion. And again, I don't usually use that treatment with a fusion, but we're just testing them, or we're testing the range of motion, and they go, I can't move at all. I'm very, very stiff. Oftentimes, it's a matter of not cognitively convincing them or telling them they're doing it, although that's worth, I'm assuming you said to her, look, you're doing it. What do you mean you can't do it?
Yeah.
It's kind of like at my house, my kids say, I can't. I say, I can doesn't live here, right? And so sometimes, though, it can't be through like our mind. It kind of has to penetrate our reflexes. And what I think, and I think we're not disagreeing, but sometimes when you do the movement, maybe to end range, and your brain then says, wait a second, I can do that comfortably, on a subconscious level, that then begets better movement.
Yep, absolutely.
But I'm sure there's like mechanoreceptors. I always call them, I'm like you, I love educating my clients, and I just call them computer chips. Have you ever heard me say that? Like, well, we need to tell the computer chips in your back that you can go that far and you can go that fast. And then sometimes I'll even say, there's a condition when you have a stroke that, I could move the person's finger, and I say, am I moving it down or up? And they have no idea. Am I moving it fast or am I moving it slow? They have no idea. Mm-hmm. And when that gets disrupted, to retrain that is a task, but that's when they're like, you got a doctorate degree to figure out, do that because it feels good to do that a whole lot more. But it's way more nuanced than that. Don't get me wrong. In fact, sometimes in the old school, they'd say, that hurts, just do it. And because we need to get that motion. Right. And I don't practice that way. I don't think you do either. But let's talk even a little bit more. Let's sidetrack a little bit from the nuts and bolts of how we approach somebody who might have some fear avoidance and we got to retrain motor skills. How do you take that person who, let's just take another scenario. They had a disc issue like we talked about at the beginning. Mm-hmm. Then they have the instability, and that does sometimes lead to a fusion unless we can get the muscles to do what a fusion could do. But the muscles can't do it, so then we got to put some screws into the spine to keep it from moving around. Mm-hmm. Now I'm 55 years old, and I still want to play golf. I'm not going to be in the NFL or the PGA, I know that, but I want to try to keep my back healthy. Can I come to you, and can you help me with that?
Yeah, absolutely. So just because you've had surgical intervention doesn't mean it needs to take away from your functional activity. Mm-hmm. And at least having a conversation or a consultation with somebody who understands biomechanics and how a surgical intervention like a fusion can affect a golf swing is important for the conversation just alone. Not to mention what we can do with regard to opening up the hips, or maybe adding a little bit of more rigidity to the thoracic spine, because obviously you've got that fusion and it changes that whole kinetic chain. So just the conversation alone, I think, is valuable, because you're going to have an understanding of a little bit of the why behind what's going on, and then you can go and own that on the golf course, or you can go and own that on your CrossFit workout, if that's the case, where, exercise may come up on the board and you may go, that one's probably not the best for me. I may have to change it up just a little bit. So it's not taking you out of the activity, but it is giving you an understanding of how do I regress it or progress it to meet my functional goals and needs.
Yeah, I like that. Yeah, I think too many people, one of the things that I see in your treatments, both your soft skills and your hard skills, is you're giving people hope. Look at your reviews. They'll say, I never thought I'd be able to do that. Yeah. And that's just a testament to, you can be the best therapist with the best techniques and get their joint moving just perfectly and, stretch the muscle or nerve just right and be a jerk. Or you could, I guess, be a super nice person that doesn't know what the heck they're doing. But when you have both, that's like dynamite. And I see that in your practice. I'm wondering too, when you talked about how the hips relate to the spine and the thorax relates to the lumbar spine, we call that regional interdependence. Could you talk to our listeners about how important that might be? And I'm going to throw a curveball at you. Let's get out of the low back now, and let's talk about the shoulder. Mm-hmm. Maybe shoulder impingement let's go with athletes, your wheelhouse. Let's talk about an overhead athlete, maybe volleyball or something. And they come into you and they say, whenever I do anything overhead, it hurts right at the top of my shoulder, and it's been going on for 6 weeks. Yeah. Where is your brain going? What are you looking at? And never mind, let's maybe set the soft skills to the side, because I know you got that. Mm-hmm. But what would you end up being what do you, I always say to my clients, I'm not going to start pulling wires or changing tires until I've run the scanner. And they know what that means, because it's a car analogy, of course. But I'm going to look at everything first, and then I'm going to go attack what I think is the big things. What things are you expecting to show up on the scanner.
Yeah. So we talked about regional interdependence, where the seemingly unrelated symptoms have a connection. That's really kind of the understanding of what regional interdependence is. And so if somebody comes into my clinic, volleyball player who's got issues in their serve, and they're telling me it's the top of my shoulder, obviously, that's a great clue. But because we are a dynamic human being, we have to understand that in the system, there are related parts. And so when they come to me, I'm not just checking the shoulder. A lot of times I'm going to that last because I want to check off the list. Okay, is there anything going on in the cervical spine? Have they had a fall? Did they fall down after a serve? Or did they slip on ice during the winter time?
Yeah.
And that is seemingly unrelated.
Yeah.
When they go to do a serve in volleyball and their shoulder is hurting, it may have been something to do with a change in the cervical spine.
Yeah.
So I'm checking the cervical spine. I'm checking the thoracic spine. How does that look? Because in order to even get into that position for a good serve, we have to rotate the spine to get there. So those are just two areas. We've heard of this above and below type of approach before.
Sure.
So it's really important that, saying it is one thing, but then actually doing it and checking it is really another thing.
Yeah.
And sometimes you lose the client for a second or two because they're like, wait, I have shoulder pain here and you're touching my neck. Yeah, that feels good. But you haven't touched my shoulder yet. And I ask them maybe a few treatments down the road, how's your shoulder been feeling? And they go, well, actually, I haven't noticed it too much. And they're confused why,
You haven't touched their shoulder.
Exactly. You've been treating my neck, but my shoulder's feeling better. So a lot of the times I'm not disregarding what the client's saying, but I'm trying to find the nuance in what they're telling me so that I can, have a really guided exam where I can say, okay, at the end of me talking to the individual, I can go, okay, here's my priority list. I'm going to check off the cervical spine and I'm going to check off the thoracic spine before I even touch the shoulder, because then I can have an understanding. Well, I can at least put those in the back of my mind in my working hypothesis.
Yeah, I love that. Maitland, in his book, Vertebral Manipulation, has a whole chapter on subjective and listening to our clients. How are you going to listen to your clients if you have 15 minutes to do an exam? So, I mean, I'll take 15 minutes or more just to listen to them.
Yep.
And they claim in that chapter that 80% you can get 80% of your information from listening to them. I don't know how you quantify that. I mean, maybe that's true.
Yeah.
I'm putting my hands on them too,
right,
but I'm being guided by what they said. And just like you, half the time I find myself going, I promise I'll get to your ankle. I promise, even though I'm going to be looking at all sorts of things first. And I actually do palpation last.
Yeah.
And the only reason I even care about pain when they say there's pain is how it correlates with the testing that I'm doing and how it correlates back to what they told me. So if for those of you unfamiliar, to say, where does it hurt? Oh, it hurts there. And then you go chase that can be a really risky thing to do. Mm-hmm. And Blake and I really believe in regional interdependence, which accounts for the whole body. And I think it just honors people better in the same way that your soft skills isn't cookie cutter. You try to tailor your interactions and your discussions with what they want to talk about. And oh my goodness, that gets them better. And so our time is up now, but I really appreciated hearing your perspective, because that falls in line with, I think, what we owe to the profession in a way that we can get people moving and moving better and then feeling better. It's our tagline, but we really believe it. Now, there's times when we have to get people feeling better so they can move better, so they can feel better. But we're not going to chase pain. We're going to get to the root of your problem, or we're going to find somebody who can.
Yep.
And I appreciate the time that you spent today, Blake.
Yeah, absolutely. It's been an honor, and hopefully we can continue these down the road where, people can get some value out of the videos before they come into the clinic. It's one thing to read a review. It's another thing to, just get a suggestion from somebody. But it's important that people see us and we provide value to them before they even walk in the doors.
Yeah, you sure provide value. So thanks so much.
No problem.